Good morning. This morning I want to talk a few minutes about methadone. Methadone is a very commonly used opioid. You see, we can test opioid addiction nowadays, like there are tests that identify these controlled substances like amphetamines, benzodiazepines, cannabinoids, and oxycodone, phencyclidine, and even tricyclic antidepressants. We can see all of them in drug screening tests. And opiates also can be seen. Like methadone, you can actually test for it. A positive test, you need to confirm it. Many times, the most important thing is gas chromatography, mass spectrometry. That's the most widely accepted method for drug confirmation. Remember that gas chromatography, mass spectrometry, GC by MS. Now, methadone is often used in opioid addiction. You say, we know naloxone. Naloxone is used for like opioid poisoning, and naloxone administration, it actually saves lives, especially when a patient is on morphine, for example. But remember, even naloxone can precipitate a withdrawal syndrome in a patient who has recently taken an opioid. So naloxone administration can provoke an acute withdrawal in the treatment of opioid addiction. I'm going to explain that point. Now, methadone and buprenorphine, these are long-acting opioids. That's why they are substituted for the shorter-acting opioids like heroin. So in heroin addiction, we use substitution therapy, and that's where methadone comes. Methadone, you can give it orally, like once daily, and it has to be given under a supervised physician. Same with buprenorphine, another longer acting opioid that helps in the treatment of heroin addiction. So opioid addiction, these two medications, folks, methadone, buprenorphine. And to give these medications, you need a special license. And these two medications, their advantage comes because they have a long half-life. That's the most important point. So, but the other problem you need to remember is even in substitution therapy, when a patient is on methadone, he is still dependent. He is still opioid dependent. Do not forget that, because if the patient is terminated abruptly, the patient can go into withdrawal syndrome. So even when you give methadone to a patient in the treatment of opioid addiction, and if you abruptly stop it, the patient can go into withdrawal syndrome. So methadone has a great value in our society. You see, 5% of population in the world today is in the United States, but 25% of the drugs, the narcotics, are consumed in this country. So it's a big problem. And this substitution therapy, when you treat a patient with addiction to opioids, is widely used. I mean, here in the United States, we can use methadone and buprenorphine in these patients, and there are countries like Netherlands or Switzerland where they substitute heroin with heroin. Isn't it funny? I mean, if you have a heroin addicted patient, they actually give you heroin, and there are cohort studies actually shown the benefit of such an approach. So that drug culture that started in 1960s never left us, and we need to be concerned about these patients and treat them. Ultimately, what matters is the patient's own willpower. That's what matters in this problem. Now, the second thing is the use of methadone in the treatment of pain, the pain control. You see, opiates act by inhibiting the pain and also stimulating the opioid receptors in the central nervous system, and also the descending brainstem pathways that are associated with the pain inhibition. So the opioids directly stimulate the descending brainstem pathways associated with pain inhibition. That's how the opioids act. And morphine is the most widely used opioid for the treatment of postoperative pain. But other medications also have a role, like other opioids like Methadone and hydromorphone. We use those things also. And methadone can also be given intramuscularly or orally, and you usually give in the dose of 10 milligrams every 4 to 6 hours, and that helps. And as I said, the main advantage is the long half-life of methadone. It acts like 10 hours. So when a patient with morphine dependence comes to you, you can use methadone because it has a long half-life, and also its ability to prevent withdrawal syndromes in these patients with morphine dependence. So these medication, methadone is useful in those two ways: the substitution therapy in opioid addiction and also the pain control. And one of the side effects of methadone you need to remember is myalgia. You see, cholesterol lowering drugs like simvastatin or zidovudine, like HIV drug, and L-tryptophan, epsilon aminocaproic acid. These medications can cause myalgia, and methadone can also cause myalgia. It can cause arrhythmias, ventricular fibrillations, a long QT prolongation on the EKG, and irritability, dizziness, hypotension, collapse. All those side effects can be caused by methadone. But the most important points I want you to remember are: it's useful in the opioid addiction along with buprenorphine, and also it's useful in the long-term control of the pain. Hope those points will help you. Thank you very much.